Okay. Hello there. Here we are in week three of the psychopharmacology course. And the video lecture this week is going to be on um, selective serotonin reuptake inhibitors. I know we talked about this last week, and I wanted to get into them a little bit more this week. Um, I mean, there were two reasons for that. One is because they're very important, as you probably see from the book. But the other is because talking about serotonin reuptake inhibitors does a lot as far as introducing some important terms. What I'm going to do in a minute is pull up a PowerPoint slide that I will talk over while I am while we are I'll talk over while it's playing. But one of the biggest points of it is to cover some of the major issues that are important in psychopharmacology. So I'll not only be covering SSRIs, but also talking about some very important topics that are essential to understand when it comes to psychopharmacology in general. So why don't we get started here? I'm going to pull up the screen right now. Here it is right now. Okay, and then I'll just pull this up here. Okay, so like I said, what we're talking about today is selective serotonin reuptake inhibitors, which are one of the more common types of uh, um, psychoactive medications, and we'll talk about them here. And I know we talked about them last week, but again, my reason for wanting to cover them today was to go more in depth as to about these medications and their treatment for depression and other psychiatric illnesses, and also to introduce some of the more important concepts that we talk about when we talk about psychoactive medications. They're used mainly in depression, mainly treatment of depression and anxiety disorder. Okay, now look at this last one. SSRIs increase the extracellular level of the neurotransmitter serotonin by inhibiting its reuptake into the presynaptic cell. Now, this is what I wanted to start addressing. It ties in a little bit of what we talked about in class last time, but I want to cover a little bit. Notice the terminology may be rather complex, but look at what it's saying. It increases the extracellular level. Remember we said this is what it does. It reuptake inhibitors, which are a common type of medications, will increase the amount of a neurotransmitter that is in the brain. So what happens here is because it inhibits, and what it does is it increases the amount of a neurotransmitter in the brain, the extracellular, outside of the cell level of a neurotransmitter, by inhibiting, by keeping it from being reuptaked into the presynaptic cell. What that means is exactly as we talked about last week. A reuptake inhibitor is a type of medication. In this case, this is one specifically related to serotonin that increases the amount of a neurotransmitter by keeping that neurotransmitter from being reuptake back into the cell. So what that allows is for this amount of the neurotransmitter to still be out in the brain because it is kept from being reuptake into the cell. It's a very important way that some medications work, and in this case, particularly SSRI. Okay, let's just the first SSRI was Prozac, which is also called fluoxetine. Fluoxetine is the other name for Prozac. They are structurally unrelated. So what that means is the only thing they have in common, so each of these SSRIs, fluoxetine, sertraline, paroxetine, fluvoxetine, citalopram, and escitalopram, they are not chemically related. The only thing they have in common is, again, they are reuptake inhibitors. They allow serotonin to be back into the system, to back working in the brain by to be back working in the brain by keeping it from being reuptake back into the cells. Okay. So what that means is the fact that they're structurally unrelated, the fact that they do essentially the same thing, but they're structurally unrelated, may be why some patients benefit from one SSRI and others do not. This is just chemical structure of it. I don't know if you know anything about chemistry, but it's a little interesting to take a look at what each one of them look like. Notice the one thing you can't tell, even if you know basic chemistry, even if you've ever seen a chemical compound, what you can tell right away is there's nothing similar about them. Like I said, the only thing they do is that all of them have some effect in keeping serotonin from being reuptake by the cells. It again increases synaptic serotonin levels by inhibiting the reuptake. Now, it usually takes weeks for the medication to be effective. So it doesn't just what this suggests is that getting more serotonin into the brain, probably getting more serotonin into the brain probably isn't enough. It has to be sort of a steady amount of serotonin going back into the brain. So just getting some more serotonin in the brain probably isn't enough. It needs to be a pretty steady increase in the amount of serotonin. This is just an interesting picture of how the whole thing works. I mean, I'm not going to go into all the chemistry of it, but it is kind of interesting to look at, to look at some of the way it works, some of what's going on here. Serotonin. Now, if you notice, serotonin SSRIs, all of the SSRIs are used for major depressive disorder, so they all were used for depression. Each one of them is used for some type of anxiety disorder. But the only thing that they're all used for, the only thing that they're all licensed for, the only thing that the FDA, this is an important thing to keep in mind, licensed indication of a medication. Licensed indication of a medication means it's what the FDA has specifically said the medication is approved to be used for. Now, these are some things that the SSRIs can be used off-label. Off-label is an interesting thing what that means is very often medications have an off-label use, which means they can be used for treatment of conditions that haven't been specifically approved by the FDA, provided there is research support for using them that way. And one thing I wanted you to keep in mind with SSRIs, and this is pretty much true of all psychiatric medications, but particularly of SSRIs, notice how many different things they all can be used for. So when you increase the amount of serotonin, I want to go back to something that says, serotonin receptors are located throughout the body, especially in the GI tract. So notice that's another thing I wanted to point out to you that will come up over and over again when we talk about pharmaceutical medication. And that's this idea that the neurotransmitters, the chemicals that are being thrown back out into the body, have an effect on depression, but they also have an effect on a lot of other parts of the body. Notice what it says here, the serotonin receptors are located throughout the body. So if you send more serotonin out of the cells, it's not going to be just in the brain, it's going to go throughout the body. And so it can have an impact on things in the GI tract. Notice here, when you talk about some of the things it can be used for, pain, irritable bowel syndrome, menopause symptoms. Look at all the things. You can just look here of all the parts of the body that can be affected by having more serotonin in the system. Not only mood, but stomach, irritable bowel syndrome, genital areas, menopausal symptoms, and premature ejaculation can be impacted. Skeletal system, pain, fibromyalgia, also pain. So notice that what's happening, and this happens a lot with all the medications that we're going to be talking about throughout this course, is that when you start throwing different neurochemicals into the body, into the brain, it's not just going through the brain, it's going wherever there are receptors for that neurochemical. And so here you've got a whole bunch of different areas of the body that can be impacted by increased serotonin. Pharmacokinetics is, excuse me 1 second here. I'm going to put this on pause. I just want to grab one thing here. Okay, I'm going to put the PowerPoint back up. I just wanted to grab my phone because I wanted to follow along with something else while I'm reading from this one. Okay, so one of the terms that we're going to be using, or that you see used a lot throughout any writings or lectures on pharmacology, is the term pharmacokinetics. And I wanted to give you a formal definition. Pharmacokinetics is the branch of pharmacology concerned with the movement of drugs within the body. Okay, I want you to take note of this word, pharmacokinetic, because that has a big deal. It's a big deal with any medications, but particularly when it comes to psychiatric medications, because psychiatric medications, people can get surprised by how much it impacts other parts of the body. Because it has to do, if you think about psychiatry isn't even isn't even the branch of medicine related to the function of the brain. That's neurology. So because psychiatry has a sort of vague definition, it's the branch of medicine related to the treatment of mental disorders. Because that can be somewhat vague, people are sometimes surprised, and because it can be seen as separate from a lot of the more specific areas of medicine, people can get surprised by the impact that psychiatric medications can have on the rest of the body. So, pharmacokinetics can be very important, a very important topic when it comes to psychiatric medications in particular, because it's not something that people necessarily think a lot about. So let's talk about, well, particularly with SSRIs. So these are some of the areas of pharmacokinetics that are often important when talking about psychiatric medication. How well is it absorbed into the system? How well is it distributed throughout the system? And how is it metabolized? Because, and what that means is, at some point, the medicine is stored somewhere. It's stored and passed through the body. So it's distributed throughout the body, but then it's stored somewhere until it passes out of the body. So, these are three very important parts related to the issue of how psychiatric medications are moved within the body, and how they're moved throughout the body, how they're distributed. So the three things here: absorption, and with SSRIs, they are absorbed orally and have peak effects in the range of 3 to 8 hours, maybe slightly increased by food. So what this means is when someone has when they've been taking serotonin for about 2 weeks, when it's had its peak, when it's sort of built up in their system enough that it's going to have its effect, then when the person takes the medication each day, it's added impact by having a new pill in the person's body every day. Peak impact is about 3 to 8 hours after taking the medication. It is distributed throughout the body through plasma protein binding. We don't need to go into detail about that. But the idea that how the medication is distributed throughout the body is important. It's just the thing I want to take from this, and it's metabolized in the liver. So that's why it's actually why it's very important for someone on SSRI to have their liver enzymes checked on a regular basis. These are just some specific numbers about them. Half-lives, meaning, half-lives is the term for it. You'll see this in a lot of stuff about any medications, any chemicals really, but medications included, where they talk about this is how long it stays in the body. And the idea is that this is how many hours it takes for half of the medication to pass throughout the body. And notice how fluoxetine, which is the oldest one, actually stays in the body the longest. And so the more you get into some of these newer ones, the lower the half-life is. So this is considered to be one of the limitations of this older medication, is that it stays in your body for a long time. It's not that the effect of these medications don't last. It's that the medication themselves stay in the body for much shorter than fluoxetine does. These do maximum daily dose. Notice how there's a difference. This is another thing that I wanted you. This was one thing, not specific about SSRIs, but about psychiatric medications in general. Notice that there's a wide range of the daily dose. You go from 20 milligrams to 200 to 300 milligrams. This is sort of the overlap of what they do. This is some chemical stuff here. We'll pass by this stuff. Okay. 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 These are some terms I wanted you to be familiar with. So I wanted you just to, I certainly don't mean you to memorize or fully even understand these specific things as they apply to SSRIs. But I did want you to just be aware of some of these terms as they are used in psychopharmacology. So let's start with dose response curve. And what that is, dose response curve is when is how long it takes for the body to respond to a medication once it is in the body. So the dose response curve is sort of, that's too many back. But I said before that the length, that it's 3 to 8 hours, that it's 3 to 8 hours after taking the medication that tends to have the most impact. This is more a study of its impact over time. So this is where that comes from. The dose response curve is how long a medication is how long it takes for a medication to be in the body before it has to have effect, and then its effect after a certain number of hours. So as we said before, 3 to 8 hours is the time where you have the maximum effect. That's part of the dose response curve. But the other part of it is, what is its impact the longer it's in the body? Selectivity is the degree to which the medication impacts the part of the body that it's meant to impact. So remember when we went before and we talked about how medications can impact a lot of parts of the body. Selectivity is that measure of how much the medication impacts the part of the body that's the targeted area. So in this case, it'd be the brain. I mean, even though this, it's not a neurological medication, its impact is, as far as a part of the body, is primarily on the brain. So selectivity in psychopharmacology would be a measure of the degree to which the medication actually impacts the brain, instead of having more of an impact in other parts of the body. This term here is specifically related to the serotonin. This is just a measure to which it does what it's supposed to do. Dopamine is also something you're trying to get more into the brain, and for depression, remember that you're actually trying to lessen for mania, but for depression you're trying to get more out into the brain. And so this is the degree to which it blocks serotonin. This is the degree to which it blocks dopamine. Now, these would be measures that are only these are measures just of the specific medications as they relate to the SSRIs. because SSRIs also tend to have an impact on dopamine. It's just not their main. It's just not their main. It's just not their main thing. Dopamine is impacted, but the main thing it impacts is serotonin. This isn't. This is just the anticholinergic. The reason why the anticholinergic effect is because anticholinergics can cause can cause some side effects. So basically what this is saying is that it's got, this medication is the most likely to have a side effect taking that medication. So I'm going to skip some of the, I mean, some of these are just very specific as far as the chemical makeup of them. These are just, it's interesting to consider some of the pros and cons of the medications, not just to know about the specific medications that we're talking about, but just to consider what are some of the pros and cons that you have to consider for any medications. The fact that this stays in the body, remember I said that was actually considered one of the negatives because it's an older one, which is one of the things that the newer SSRIs were trying to deal with. But in actuality, when you have a medication that stays in the body longer, that has a longer half-life, and remember, this is the one where the chart showed that the half-life was huge compared to the other ones. One of the reasons that's good is when you it can be useful for someone who has medication non-compliance issues. They just don't take their medication that they're prescribed, because you can even if it's prescribed on a daily basis, if they don't take it on a daily basis, they can still get some of the benefits. Because if you remember how long the half-life of Prozac, the oldest one, the half-life of it was more than a day. So you could actually have somebody take, even though it's usually prescribed to take every day, you could have someone take it, skip the next day. It's not recommended. But if you had someone who was non-compliant, they could take it, skip the next day, and still have some benefit. Not as much as if they had taken every day, but some. So medication provides increased energy. But notice here, this is always increased energy, but also could be increased anxiety and trouble sleeping. These two are often related. Increased energy, if it sort of combines with other problems for the person, could turn into increased anxiety and increased problem sleeping. Lustrol, which is the other one, the next one, fewer side effects. Because it doesn't stay in the body as long and has less active metabolites. The metabolites is always something to consider with psychiatric medications because they can cause some side effects. So you want to watch that. It tends to have a stronger impact on the GI. So notice here, as we were talking about before, when you're talking about a medication, you have to watch for its impact on other parts of the body. Serotac, it has the one thing about it has the worst side effects of all the medications. So it's not quite clear why that happens. But it for whatever reason has the most. So Sarah said that I actually haven't seen this. I don't see this used that much, and I think that's probably one of the reasons. But I guess what I'm really trying to say about this, or one thing that's particularly noteworthy about this issue, is notice this is not a medication you see that often, and it's also the worst side effects. Typically, when a medication has particularly bad side effects, you will see it drop out of use pretty quickly. All this stuff here, all these cons that we talked about, buildup of metabolism, increased anxiety. The thing that tends to cause a medication to really fall out of use is when it's got a bad side effect profile. Phevarin, just wanted to show you the name of it. It's also considered to be pretty bad in terms of side effects. Cipram, citalopram. I'm just going to skip through it. I actually just wanted to show you what the brand name was too. So it's a Prozac's the only brand name I see on any regular, on any sort of frequent basis. Some of the adverse effects, some of the side effects you can get from SSRI: nausea, sexual dysfunction, headaches, vomiting, dry mouth, and pain. Notice again, like we talked about before, genital areas, head, stomach, and even mouth. These are all areas. Notice how many parts of the body are impacted by these medications. Here's some other ones. Increased risk of bleeding, weight gain. So here's the stomach again. And just there's a whole bunch of other ones. This this has just become just so commonplace. It's always weird, but it's just become commonplace. It just always has to be brought up, the fact that SSRIs, one of the side effects can be the start of suicidal ideation. I'm just going to skip it. I guess all I want you to notice as I'm skipping through these slides is notice how many side effects there are. And they're still going. Now they're talking about sexual side effects. Notice just how many side effects there are. This is a term I wanted you to be familiar with. Hold on a second. It's called I'm not going to go through all the details in the other slide, but it's called the serotonin syndrome. Sometimes serotonin can interact with another drug that also has an impact on serotonin. So basically throw a whole bunch of serotonin in the body, and that can be life-threatening. Notice where it can impact not only mental state, but also neurological state, not only in the head, but also throughout the body, throughout the muscular system, and can cause a lot of problems in the stomach area. So basically, serotonin, if you just throw too much into it, if you take a SSRI and throw it together, because remember, SSRIs are increasing the amount of chemical in the body. And so if you have something else that's increasing the amount of serotonin, it can cause a real big problem. Well, let me not skip over this. So this is the process by which, it's called SSRI discontinuation syndrome, and it occurs on abrupt withdrawal of SSRI. And I just wanted to point that out. Notice you've got the syndrome, and it occurs with other psychiatric medications as well. You've got the syndrome that comes about when someone just stops SSRIs. So someone may say, "Oh, I'm not so depressed anymore, so I'm just going to stop the medication." Well, that can be real dangerous. And there's all these details here, but I'm going to skip over them, because what I just want you to realize is with psychiatric medications, there can be a real danger of if you stop them. if you stop them abruptly. Serotonin. So having less serotonin in cells, because remember that's what happened. It keeps the serotonin from being stored in the cells and throws out into the body. It can so less serotonin in the body can lead to an increase in bleeding. I'm not going to go too much. All right, I'm going to stop it there. So what I really wanted you to notice throughout all that, there's a couple things. And you'll see this over and over again. The one thing you will notice is that this whole idea of serotonin, dopamine, and some of the others, there really are only a few major neurotransmitter chemicals that are involved with psychiatric medication. And those chemicals affect a lot of different parts of the body. So, it's really interesting to keep in mind how, as much as these can be helpful for certain mental disorders, it's useful to keep in mind how much it impacts other parts of the body. All right, let's pick this up on Thursday. Make sure to view the other videos that are in the assignment section, and I will see you on Thursday.